Welcome to our podcast series, Decoding Breast Cancer, where I, Laurie Ann, ask Dr. Etienne, our Oncoplastic surgeon, the questions that you are too scared to Google. So one of our previous podcasts about risk factors, I had a question. If you are on HRT, hormone replacement therapy, and one of the risk factors is if you start very early as a young child with your menstruation and then only going to menopause very late, you might increase your risk for breast cancer. So she wanted to know, if you stay on hormone therapy and that extends that time for your menopause to start, won't that increase your risk to develop breast cancer, Dr. Etienne?
Hi, Laurie. In that podcast, I explained that actually the evidence says that using HRT below the age of 60 did not increase the chance of you getting breast cancer. So the short answer is no, it doesn't. Probably the biggest factor is patients starting with an early menarche, the age that they start menstruating. Because as I explained, the breast remains immature until you have your first child. So actually that first years of exposure is a much more important part than whether you have menopause at, let's say, 50 or 52 or 54. So that probably does not make such a big difference. And therefore, we can categorically say through really large series of women that have been followed up that using hormone replacement therapy in a healthy patient really does not increase the risk in any significant way.
So I hope that answers the question for the person that was interested. So now we've also discussed biopsies, and today we're going to discuss the biopsy results.
Yeah.
So you get your results back from PathCare, it goes to your doctor, your surgeon, and they now have to see what it says. So I want to know, Dr. Etienne, what does it say? What is important there, and what does it say when you get that result of one of us?
People think that you go for your biopsy and then next day you're going to have an answer. And that is generally not the case. These days, there's quite a lot of detail that the pathologist needs to have a look at before they can sign out a final result. And obviously, they want to be 100% sure that when they sign that result out, that it's going to be accurate. You don't want to tell someone that they've got cancer and a week or two later say, fortunately we were wrong and you don't have cancer. In that moment when people hear they've got cancer, there's so many emotions that go through their head. So the first thing that we would want to look at is to say, are we happy that this biopsy, the result that the pathologist gives us, represents whatever we were worried about on the mammogram or clinically? So let's, for example, say you have a patient that had a normal mammogram last year and now they see a very clear lump that looks cancerous. So we are very worried about that on the mammogram. We do a biopsy and the biopsy comes back and says normal breast tissue. Or it says something like fibrocystic tissue. That I wouldn't be happy with, because we are definitely seeing something on the mammogram, and basically what the biopsy is saying is this is just normal breast tissue. So it doesn't give me an answer. The biopsy needs to tell me what this is that we are seeing so that we can make a decision how to handle that. And I think that is a really important part. So we talk about pathological-radiological correlation. There should be concordance between those two things. So if the biopsy is not representative of whatever the concern is, then we would be inclined to say, okay, listen, we either need to repeat that biopsy or do a different kind of biopsy. Sometimes I would say, okay, we need to go and actually pinpoint that area and remove that. So that would be one small scenario when we would actually go and excise the area so that we can get a really representative answer as to exactly what's going on in that spot. So that's the first important thing is, am I happy that this biopsy represents the concern we had in the first place? The next thing then is to say, do we think this is benign? In other words, it's non-cancerous. Typical things that would be benign would be a fibroadenoma, for example. But let's say benign, do we think this is something that's inflammatory? So we do get breast abscesses or chronic breast infections or things like that can look really cancerous on a mammogram. But if we do the biopsy, it comes back as being a chronic abscess, and that isn't cancerous. It may in its own right require treatment, and it can be really problematic for the patient, but at least it's not cancerous. And then obviously the last thing was that they would say this is malignant. Now, malignancy means there are cancerous cells. We have invasive cancers and we have non-invasive, or what we talk about in situ carcinomas. These are all cancer cells or cells that look malignant. They are cancerous cells, but there's a difference between an invasive cancer and an in situ carcinoma. And that is just the beginning of that answer. So the first thing the pathologist would want to confirm is that this is a cancerous biopsy. The next question then would be to say, okay, what are the characteristics? Because not all breast cancers are the same. We have lots of different subtypes or types of breast cancer, and they all behave differently from one another, and the treatment differs. So it's not like in the old days where someone would say, oh ma'am, okay, if you've got a cancerous lump in your breast, I'm going to take you to theater and we're going to take the lump out, and then the pathologist is going to check it, and then if it's cancerous or if it's bad, then we're just going to continue and do a mastectomy. There's not a single clinical scenario where that should happen in 2025. So biopsy will basically tell us, is it representative or not? Number 2 is it benign? Is it inflammatory? Or is it cancerous? And each one of those we will then take and manage on its own merit.
So I think that's where it's important that you need to have the right doctor that's able to look at your pathology results and clinically and make an intentional decision of what's the plan next. Where if you don't, things might get lost if the result says it's not malignant, but there is still a lump.
Exactly. I think we said in our previous episode the importance when you do a mammogram and they say we're going to do a biopsy, people get upset because the radiologists don't want to just do the biopsy and take responsibility for that. But that's the reality. Someone needs to take responsibility of interpreting the imaging with the clinical scenario, with that biopsy result, to make a decision about whether we're happy that there's concordance between those things. And if not, then be able to say, okay, wait a minute, this is the most effective strategy for us to deal with that going forward.
So now, after you've seen the results and the results are cancerous, what else can we see on our biopsy report?
Yeah, so the next phase that the pathologist will then go into is, once they've now confirmed that this is a cancer, the next step is going to be for them to try and look at the different characteristics of this tumor. All cancers are not the same, so they need to tell me about the personality of the cancer, because that will determine what type of treatment pathway we are going to enter. And that's why it's so important to get a full analysis of your biopsy, not just a needle aspiration where we just aspirate cells and they just say it's cancerous or non-cancerous. We want to have a biopsy where we actually have a piece of tissue, because then we can analyze that tumor to give characteristics. And importantly, in breast cancers, they will do the estrogen receptor, the progesterone receptor, the HER2 receptor, and they will generally do a proliferation index. In other words, look at how many cells within that sample is actually in an active growth phase versus cells that are actually almost dormant, because those 4 little pieces of information is going to be able to tell me a little bit about the personality or the behavior of the cancer, and that is going to guide the treatment choices that we are going to have for patients. For some cancers, we would say, okay, we think that surgery up front would be a good option. For some cancers, we are going to say, no, this needs to start with chemotherapy or chemotherapy and anti-HER2 therapy. So it's really important that we choose the right pathway for each different cancer.
You mentioned in situ versus infiltrating. Can you see that on the biopsy result when you get it back?
Yes, so in situ carcinomas are those that are basically trapped within the little milk ducts. I always think about a bunch of sheep that's in a fenced area and they all bundle together there and they can't really escape. So they can't go anywhere else. They are just stuck there in that fenced area. So cancer cells that are within the duct are limited by that duct wall, and so they can move alongside the milk duct, but they can't move outside of the milk duct. Now, cancer cells that don't invade, in theory, can't spread anywhere. So it can't spread to your lungs or your liver or your lymph nodes even. Whereas invasive cancer means that we've got some of those cells that have found the ability to break through outside this wall of the duct, and in other words, they can then move from the duct into the tissue around the duct, and theoretically into the blood vessels or the lymphatic vessels that are in that surrounding area, and then use those pathways to hitch a ride to other places in your body. So that's the main difference between an invasive cancer versus an in situ cancer, is the risk or the ability of that cancer to be able to spread to other places of your body.
So if you have an in situ cancer, that should be good news.
Yes. So in theory, I always say it's not a disease yet. It's something that's brewing inside. In that sense, it's almost like having an abnormal gene. So that gene predisposes you to developing an invasive cancer, but in itself, it's not a disease. So in situ cancer is almost the same. In itself, it can't really do anything, but it is constantly trying to develop into ways where it can become invasive. And when it becomes invasive, obviously, then it becomes an issue that it can spread. So invasive cancers are treated differently from in situ carcinomas. Because it can't spread, we don't use chemotherapy for it. So our approach to those things are completely different. The reality is in situ carcinomas are things that we really only find when you do routine mammograms. It's one of those arguments of, does it matter that we find these things because it adds extra anxiety to the patients, but we're finding things that really are not causing a risk for the patient at that very stage.
But obviously, if you left it, it can become infiltrating.
The risk of it becoming invasive differs. If you've got an in situ carcinoma that is really small, that is growing very slowly, what we would call a low-grade DCIS, then the chance of it becoming cancerous over time is actually quite small. And I would frequently have patients that are, say, 80 years old or 75, and we find this tiny little area of microcalcifications, and we biopsy it, and we see it's a low-grade in situ carcinoma. One can make an argument to say, let's just keep an eye on that and not do surgery and not do treatment, because there's a really small chance that it's going to become cancerous in the next 10 years. If you're a young patient, if you're 30 or 40 years old and you have a high-grade ductal carcinoma in situ, then the chance of you having or developing an invasive cancer over the course of the ensuing 10 years would be quite high, maybe as high as 30 or 35%. So it's not 90%, but it's still significantly high. And if you are young and you're still going to live another 30 or 40 or 50 years, then that risk becomes higher. So the way we deal with DCIS is really to try and do a risk estimation for you in the beginning. And we use all these different factors, the size of it, what the grading of it, is it a low grade or a high grade? What is the size? Is it, less than 15 millimeters, or is it a large area more than 40 millimeters? Are you a young patient? Are you under the age of 40, or are you over the age of 60? And we use those type of factors to try and do a risk assessment, and then we try and guide you in terms of what type of treatment do we think is appropriate to do this. But in thinking about that is we are trying to prevent a cancer from happening. We are not really treating something that at this stage has a life-threatening association with it.
Tell me, an in situ carcinoma, can one at that stage already distinguish what subtype it is or not?
So in situ carcinomas don't really have subtypes in the same sense that we have with invasive cancers. We have different, different descriptions, things like cribriform. We have things like comedonecrosis or comedotype. So we have different morphological features. If you look under the microscope, that you can say, okay, this has a certain growth pattern to it. And we would associate certain patterns with a more high grade or a more low grade thing. But in situ carcinoma, the important thing really is, I think, just actually two things. The one is it a low grade or a high grade? Or do we see necrosis? Necrosis are cells that are dying, and that generally suggests that you've got cells that are a little bit more active. They are outgrowing their blood supply. So do we see necrosis within there or not? Those are the two factors that I think would play the biggest role in determining whether this is a high risk pattern of growth or a lower risk pattern of growth.
So the question I also have with this in situ, I'm thinking of a specific patient now. Will it be anywhere else in your body if it's only in situ, or is that where it's localized, that spot in your breast where it hasn't moved anywhere, or could it have a lymph node involved or not?
If you could know 100% that this is in situ carcinoma, then there's no way that cancer can spread elsewhere. The problem is, let's say you have an area of 4 or 5 centimeters where you've got in situ cancer that's growing in the little milk ducts. And you have a 1 millimeter little area where there's actually cells that have become able to break through into the surrounding tissue. Now you've got a little focus of what we call microinvasion. So you can only have spread to lymph nodes if you have invasion somewhere. The question is, how good are we at actually being 100% certain that there are no areas of invasion? Obviously, if you have a very small area of in situ carcinoma and you have a low risk type of growth pattern, and you are an older patient with a breast that's really low density on mammogram, so you can see really well what's going on, the risk of you having an area of invasion that we can't see or can't find is going to be very small. But if you're a 30-year-old patient with a really dense breast and you've got this area of calcification, and we do a biopsy and say, well, actually it's 3, 4, 5 centimeter area of cells that are just growing in these ducts, and it's high-grade cells. These are cells that are actually quite active. Now you are taking that piece of tissue and you're doing little sections every couple of millimeters or a centimeter apart. So you're sectioning through that specimen, looking at the different levels, but you can never sample 100% of all of that. And that then means that there's a small chance that you can miss a little area of invasion in between your cuts. And now that patient may theoretically present with a lymph node. So in principle, we'll say in a young patient with a high risk DCIS, there's about a 2% chance that you may find a lymph node in that patient. It's a very rare scenario, and it's not because of the DCIS, it's because you've got a sneaky area of invasion that sits in between the areas that you were sampled, so you don't know about that, and then 3 or 4 or 5 or 6 months later, the patient comes to you with follow-up and you say, but wait a minute, this one lymph node looks a little bit enlarged, and you do a biopsy and you find, oh my goodness, there are cancer cells there. The problem with that is that the patient was happy that everything looked good and we've caught this in time with all the evidence we have, and now you're telling them, oh, but actually we do have some spread, and now you go back into now invasive cancer territory. So it's always quite an emotional ride for those poor patients. The one thing about cancer that you need to know up front is the word uncertainty. So if we could have certainty in cancer, if I could be certain that you have no spread elsewhere, then I wouldn't give you chemotherapy, because we don't give chemotherapy to treat a lump in a breast. If we could have certainty that your cancer would never come back, you wouldn't have to see the doctor ever again. You could just stay away. So everything in cancer is about, we have a certain level of uncertainty that the cancer may come back, or that the cancer may have spread, or that we may have a positive lymph node. And we are constantly trying to make that uncertainty as small as possible, but we can never get rid of that completely. You know, I see lots of patients that come and say, doctor, I want you to do a mastectomy. I always ask, okay, why? The number one answer is because I don't want to take any chances. I don't want this cancer to come back. So people are seeking for certainty. They want to do things to say, okay, now if I do this, then I can be certain that this thing won't come back. And the reality is, often once we have the discussion, I say, well, even if you do a mastectomy, you still have, this percentage chance that your cancer may come back locally in your chest or whatever. And you have the same amount of chance that it may spread somewhere. So now we start coming back into that territory of uncertainty. And it's an important thing to make peace with. Some people never make peace with that. They run around to numerous doctors, numerous places. They spend huge amounts of money trying to get to, okay, someone will tell me that they're 100% certain that my cancer will never come back. You're never going to find that.
Still on the topic. So if you are one of the patients with in situ cancer, how often do you still have to have follow-ups? Do you have follow-ups when they've taken it out?
The only follow-up you need with in situ carcinoma really is to make sure that you don't develop an invasive cancer. So they basically enter into a program where they have a mammogram once a year. We'll normally do the first mammogram, let's say 6 to 9 months after the initial operation, so that we have a baseline to see what the breast looks like. And then after that, once a year. And in principle, we want to then look for two things. We want to see, are there new areas that looks like more DCIS which develop, and maybe 1 in 4 or 1 in 3 patients, at some stage, they may have another little area that looks like DCIS. Or do we see evidence of an invasive cancer that develops, which would obviously then need further treatment. But in principle, they do follow up. They should have a mammogram once a year, as long as they remain healthy and active.
Do they need a CT scan or not?
Definitely not. Unless the patient has symptoms that are unexpected. There's no guideline that suggests that you should have CT scans in someone that's had in situ carcinoma.
The last question on that is, so often when women now find out they've got that, they want a double mastectomy. I think it's just a natural thing for a woman to think, if I remove both my breasts, then the cancer can't come back there. So for your in situ patients, would you just do a lumpectomy area or just remove that area? How would you go about it with in situ?
So I think the first thing, if you have an in situ carcinoma, is always the question is, why did you develop these cells? So the same indications for genetic testing as for invasive cancer would apply. So if you are someone that's under the age of 50, or someone that's had a family member that's under 50 who's had breast cancer, or someone who's had a family member with ovarian cancer, or a male patient that had prostate cancer at a young age, or someone who had pancreatic cancer. So if there's certain patterns that I would say, okay, this person needs to have genetic testing. So if you have a genetic test which shows that you have a gene that increases your risk for breast cancer, definitely I would advise that the patient consider the option of a risk reduction mastectomy. If there's no concern about genetic testing, the next thing would then be to say, okay, how big do we think this area is? And this is often difficult because, remember, the way we normally pick up DCIS is because there's a little area of microcalcifications. Calcifications are little calcium crystals that form because there's something in that vicinity. The calcium that you're seeing on the mammogram is not the disease. It is your body's reaction to the disease. So you can have a big area of DCIS, but actually just a small area of calcification. Or you can have a big area of calcification because of other irritation and actually just have like a minuscule area of DCIS within that. So typically what I would do is I would say the first step for me is, once someone's had a biopsy that says DCIS, is I want to go and excise that area or remove that area where we see the problem, because I want to define how big it is. I want to make sure that there's no invasive cancer that's in that same vicinity. And that puts us in a position then to actually make a decision about what your risk is. So if you then have a very small area, we removed it completely, there's no invasion, then in theory we would say we don't need anything else, you just continue. And the majority of patients actually would be like that. We use a scoring system, we call it the Van Nuys scoring system, to try and help you to calculate your risk. So first step normally is excise the area so we know what we're dealing with. If you then fall into the high risk category, that's the patients that I would say maybe having a mastectomy is actually a good idea, because we think your risk of having more of these areas in your breast is actually quite high, maybe 40%. And we think that you have at least a 20-25% overtime of developing breast cancer. Then we would say maybe having a mastectomy or doing a mastectomy is a good way of controlling that risk for you. One always has to weigh up the risks of the surgery and the complications of the surgery versus the risks of the disease. So remember, there's no operation that has zero risk. Every operation has a potential risk. And you always have to ask, you went through complications with your surgery and things yourself. So you have to always ask yourself, if I knew this was going to happen, would I have still chosen this route? If you have a cancer that wants to kill you, then people would, you're willing to sacrifice a lot more. If you've got something that really has almost no risk for you, then you would say, well, I'm taking a big risk with the surgery that's not really benefiting me that much. So I need to be very cognizant of, what am I gaining for the risk that I'm taking. You do get a group of patients that have an in-between risk, an intermediate risk group. And this is frequently where people would sometimes advise radiation to that breast. Now, guideline-wise, and people would often say, well, that's standard of care is to do radiation after DCIS. But I'm constantly asking myself, we are doing something to that breast that's irreversible. It's going to leave permanent damage in that breast. It's going to make future mammography and future diagnosis a little bit more difficult. It's going to make surgery in future a little bit more difficult. And we are doing that to treat something that can't kill you. So in my mind, I tend to try and avoid patients having radiation for DCIS and rather try and see, can we actually excise a bigger area of the breast? Can we downscale this problem to something where we can actually do breast conservation without radiation? Or should we maybe rather do a mastectomy because the risk is that high? So I try and avoid that gray area that we often have, Because the reality is radiation in DCIS really doesn't offer the same benefits as in invasive cancers. It reduces the risk of the cancer coming back maybe by about a third, which means if you have a 30% risk and you do radiation, it's going to come down to 20%. That's still quite high. With invasive cancer, you can bring it down from 25 or 30% down to about 4%. So invasive cancer, much more protection from radiation versus DCIS. So it's an approach that tries to limit the risk and the damage that we do to the patient's breast while still giving them the best benefit in terms of protection.
So it's a very interesting topic, looking at mastectomies versus breast conservation. And I think I've got too many questions for us to continue. So what we're going to do is we're going to explore the rest of this topic in our next episode. And thank you, Dr. Etienne, for clarifying what we've just learned today in this episode.
Yeah, thanks, Laurie. I think that's a really important topic because breast diseases have a lot of emotion around it. And I think people sometimes don't want to believe the evidence because it just doesn't feel right. And I think that's an important thing to speak about. So yeah, next time we'll explore that a little bit.
Thank you, Dr. Etienne.